Good morning. Welcome to Grand Rounds. There is no commercial support for today's program. Any financial relationships of the planners and speakers have been mitigated. If you have a question for the presenter, please wait until the Q&A segment. If you are online, you may submit your questions in the question feature, and we'll read it aloud. The link to the evaluation will be posted in the chat section. And now, it's my pleasure to invite Dr. Egelum to introduce today's guest speaker.
Excellent. Welcome, everyone, and thanks for being here for another Ground Rounds occasion. And thanks to those that are online. It really gives me a lot of great pleasure to introduce Dr. Drakos. He is the medical director of the University of Utah's very historic and well-known mechanical support and artificial heart program. He's the co-chief of the heart failure and transplant, and also the director of research at the cardiovascular division. He holds the H.A. and Edna Benin Presidential Endowed Chair, and his research interests are focused on myocardial recovery in chronic heart failure setting and acute settings as well. Dr. Drakos' team is utilizing clinical and biological information derived from inhuman studies and small and large animal heart failure models to understand and enhance myocardial recovery. The original work generated by Dr. Drakos' research team in the clinical arena in his lab led to the establishment of the award-winning multidisciplinary Utah Cardiac Recovery Program, UCAR. He's the chairperson of the Clinical Integrative Cardiovascular and Hematological Sciences at the NIH, co-directs the annual International Utah Cardiac Recovery Symposium Program, and he's an elected member of the ASCI. And he's also a visiting professor at multiple academic medical centers nationally and internationally, and has mentored several individuals who've led on to productive academic careers. Not only is he well known in the field of LVAD and myocardial recovery, but I'll say he's a very excellent person to hang with. Lots of great stories last night at dinner, and looking forward to hearing his discussion about this really wonderful and interesting topic. Dr. Drakos.
Thank you. Thank you so much, Igor. Thank you, everybody, for attending. Thank you for the invitation. It's a great pleasure to be here. And we'll talk, as you heard, about heart recovery. So I like to start with this busy table, not just to make you first thing in the morning a little bit confused with too much information, but the purpose of this slide is to just show the heterogeneity of the disease. So if I go back, you will see here that the etiologies that they caused heart failure are multiple. The therapies we're using are multiple. And the response rate to these therapies varies. The timing to response also varies. And the durability of the response also varies. Again, making the point that this is a heterogeneous disease. And we will come back to this point down the talk. I also like to start with this diagram, this illustration here, which in the outer ring, you can see all of the ways that we can, all of the mechanisms that they can push the heart down and the forward remodeling, progressing to heart failure. And in the inner ring here, you can see all of the things we do every day in our clinics and in our wards and in our ICUs in order to get bad hearts to look better. And we can achieve this, as you know, doing many things. For example, if we control the tachycardia in tachy-induced cardiomyopathy patients, that's one of the most reversible known cardiomyopathies, right? If we block the RAS system, right? If we fix the aortic valve, right, with TAVR, all of these cardiomyopathies, we know that they are reversible. If we revascularize the heart, if we do cardiac resynchronization, if we convince people to abstain from alcohol, as we discussed yesterday, easier said than done. But if you achieve that, then you can improve failing hearts. And we do know that because it's happening to all of us every day. So this dogma that prevailed for decades, that the human failing heart cannot really improve significantly, it's being challenged daily from all of us in our wards, and now it made it to the guidelines, and we know that this is what we're supposed to do. So which of those paradigms can be used as a model in order to gain deeper understanding, clinical and mechanistic insight. So I'll submit to you that the left ventricular assist device model is something that can really give us a lot more insight, and we'll discuss why this may be the case. Let's go back to Dagman and many others early on, establishing that the wall stress, as you can see here, is central, right? The increased load is central in this vicious cycle of heart remodeling, getting the heart structure and function to go down. And so the hypothesis that was generated early on when ventricular assist devices came into our lives was that these devices really remove a significant part of this central thing that drives the forward remodeling. And by removing a significant part of this factor, they may be reverse remodeling and helping the heart get better. The other thing that these devices do, as you know, on top of offloading, is that they improve the systemic perfusion and the neurohormonal milieu, which, as we know, we talked about it yesterday, this is how we treat our heart failure patients. We go to the periphery. We block the RAS system, we block the adrenergic system. We work with the periphery a lot, so they do both. Now, it's an example of a patient who, let's call this patient A, and this is a responder, meaning that the heart function, as you can see in the 4-chamber view there, it got better. You can see the squeezing of the left ventricle after a few months on LVAD, how it got better. So this is a patient that responded favorably. And this is another patient, let's call this patient B, who did not respond, despite similar heart failure etiology. Both of them have idiopathic dilated cardiomyopathy. Despite similar duration of heart failure, they both were sick for 3.5 years. And despite that the duration of the intervention in both cases was about 6 months, 6 to 8 months in both of them. So why these two hearts responded differently has far-reaching implications, and we'll talk about it down this talk. So in order to understand these and other things in this field, we put together our recovery program, which is a wonderful collaboration between the clinical programs in the Salt Lake Valley, between the University of Utah Intermountain and the Salt Lake VA, and many other collaborating institutions, as you will see, from all over the country and the world. And for the scientific component and understanding the biology driving this phenomenon, we put together collaboration again with our own basic science and translational departments and other institutions from all over the world. So today we'll spend most of the time to talk about the clinical data, given that we are having a clinical audience, clinical research and clinical practice audience, and we'll talk at the end a little bit about some of the biological findings as well. As you know, somebody is doing the work. And the people who are doing the work are not the people who are standing on the podium talking to you today, as you know. There are a lot of people that they work over the years, and even these people are not only just a part of them. And some of them are already independent faculty, as you may know some of them in institutions all over the country and the world. Some of them are still in training. And these are the people that they work with us and me over the years to produce some of the evidence that I'm going to share with you now. One of the things we learned was that this phenomenon of heart recovery is not like pregnancy or death, which is all or none. It either happens or it does not happen. This is not like that. This is a continuous spectrum, like most biological phenomena, and it happens, as we will see, in different spectrums, in one continuous spectrum, and you would expect to find, and we will get to the details, about 15% recovery responders in the patients we evaluate for advanced therapies, 30% partial responders, and about 50% non-responders, and we'll get to how this is defined in a moment. The other thing we learned was that the sustainability of this remission/recovery is excellent, and we'll get to this as well. Is reproducible in single and multi-center registries now all over the world. We have predictors that can help us select these patients now, and there is an underdiagnosis kind of amyloid kind of thing that we had a few years ago, and underutilization of this path. And we'll talk about how the opportunity arrives when you have underutilization of something that is good. There's an opportunity there, right? And we will also talk about some future directions. Now, ReStage was a multi-center study that was done here in our country, and it showed in 6 sites that you see them listed here. It showed that in these 6 sites, when you select patients that they are non-ischemics, less than 60, big hearts, chronic HFrEF patients, right, but less than 5 years duration, and these inclusion criteria were informed by prior single-center studies we and others have done, right? When you do that, in this trial, we learned, and it's published already 3.5, 4 years ago now or more, and so I'm not gonna go to the details, but you can find them online, but what was shown there was about 50% of these patients can recover to the point we can remove the LVADs and abort heart transplant and other therapies and leave them with their native heart, right? So this is in these selected patients. And we will go later on the durability of these, but before I go to the durability of this phenomenon, let's talk about the incidence in all comers, not selected. Because from a business perspective, when you have a heart failure program, right, this is an important question, because one of the barriers in the field for many years, especially when somebody doesn't want to do something, they will tell you, well, this never happens. We are busy. We don't have time for zebras. And if we're going to look for a zebra and we're going to develop programs in order to find one patient every 20 years or 10 years or once a year, we don't want to do that, right? So are we looking for rare recovery zebras here, right? That was one of the barriers. Because initially, remember now, many years ago when we started talking about this, people were saying, come on, this is like Lazarus coming back from the dead. These hearts are tossed. I mean, these are patients that they have advanced end-stage heart failure. You're telling us that they're going to reverse the remodeling and you're going to remove the pumps and all of this. So people were just too good to be true thing, right? And so this was absolutely the #1 barrier for the field to grow for many years. This perception that we're looking for zebras here, right? Like the cancer patient who is going to get the cancer remission, and you will find one case every 2 years. So if we want to address the question about the all-comers, what we did and others is we went where the all-comers are being reported. And the all-comers, right, all of the patients that they get with LVADs, they are reported in Intermax. That's our national registry. So this is Omar Weaver-Pinzon, one of my mentees, who he's now NIH funded, and we just exported him to the University of Miami to lead the program there after 15 years working with us. And what Omar did when he was a fellow with us, he got the Intermax registry, and at that point in time, we had about 15,000 patients in the registry. And as we know, in those days, not a lot of programs were interested in this phenomenon, so only 1 to 2% of the patients were having their pumps removed for recovery. So we went to the rest of the patients to see what happens with them. So when we went to the rest of the patients, we found another 7,000 patients that they had serial echoes uploaded in Intermax, their reports from their institutions, like your institution, right? So we looked at these reports, and we found that in these reports, you had another 12.6% of patients that they had an EF more than 40% read in these reports by the echo readers of all of these institutions. So if you add the two, you will go to these 14, 15% that I talked to you before, right? And if you go to the rest of the patients that they had variable improvements, as we said, this is a continuous spectrum, right? You will find another 30% of the patients there that they had a median increase of the EF around 9% and a range of 6 to 14. This is all comers from all of the institutions in Georgia, in Kentucky, in New York, in California, everywhere. The reports read by these institutions, right? And the coordinators uploading these reports in Intermax. We just took whatever they reported there. Now, this is a missed opportunity because these patients could have been evaluated for recovery, right? And maybe instead of staying on the VAD or going for transplant, living with their own native heart and enjoying better quality of life. And we'll take back about this. So the Columbia group got about the same time, the same data from the same registry, and they asked the same question, and of course, they found the same results. So, and they published this about the same time we published it. Then we did this prospectively. We said the registries are good, but let's look at our own population. And because, you know, Utah, we have the surrounding states sending us patients. We talked about it yesterday, 6, 7 surrounding states. We cover about 10% of the geographical area of the country. And then we got the DC area to get a population which is far away from us, right? And we evaluated from the DC area and our area about 360 patients prospectively. We excluded the acutes, only chronic heart failure patients, and we found the same thing. So this is consistent. So these are the patients and the percentages you should expect. It's not a zebra. It doesn't happen once a year, but it's not going to happen in the majority of the patients, right? These are sick people. But this is what you should expect with the way we select patients right now. We can go to the opportunity later, but right now, this is what you should expect. Now, how to define recovery? We got together a few years ago, and we published the recommendations, and we got 35, 40 people from all over the country, and the world actually, the NIH gathered us to define what recovery should look like as a definition, right? And one of the things we agreed in this working group was that it should not just be focused on how the heart looks. Getting the heart to look stronger and smaller from the dilation, it's not good enough. What would be good enough is to show meaningful changes in the outcomes for the patients. And that should be the definition of heart recovery, right? And that's what we say here. And that was published in the flagship journals of the medical associations of cardiology, CT surgery, bioengineering, and artificial organs, that they accepted these recommendations, as you can see there. And I had the honor and the privilege to lead this group. Now, what is the durability then of this remission/recovery? That's what we're talking about here, right? So this is data from Herfield, where you can see that when they did this with their own patients, in order to show the durability of the patients they explanted for recovery, which was about 40 people with red, they compare their outcomes long-term after explantation with what happened to another 52 of their patients that they transplanted. And the reason they chose this control group for the comparison is because that's an alternative therapy you can do in these people, right? You can transplant them. And so, as you can see here, the outcomes were similar. Long-term, up to 8 years of follow-up. And then we have now data showing similar things from all over the world, right? From the risk stage, I just showed you the results that 1 in 2, 50% of the patients got explanted. Euromax is the European Intermax registry, essentially the equivalent. Berlin, Texas Heart Institute, and several other single-center reports showed the same thing. But all of these reports were small numbers, as you can see here. And when you're saying things that they are not mainstream, small numbers are not going to make it. As we discussed yesterday, when we are practicing one way and somebody is telling us, hey, add this additional pathway, you need to see real evidence and a lot of patients and hard evidence. And so these were good results, but the numbers, the follow-up, the survival, they were good results. But the follow-up, the number of patients were small. So that's why we got together and we said, well, we need to show people evidence from hundreds of patients from all over the world. So we got together about a couple of years ago, and with one of my mentees from New York, Snehal Patel, we put together this registry, which is a wonderful collaboration. And you can see here now that we have sites from all over the world that they are reporting how these patients that we win the LVADs, they do long-term. And we have now more than 800 patients that the VADs were win for recovery in more than 60 sites now, because every time we give a talk like this, we get a couple of more sites to join, like we discussed, you guys should join as well with your VAD program, right? And then you will get access to all this data to do, as you will see now, projects. And I'll get to it. So these are the characteristics of the first 450 people that we clean up the data, and we presented this in ESC in London a few months ago. And in a month in ICLT in Boston, we will present more. And you can see here that this is not happening only in young people. 30% of the patients were older than 50 years old. You can see that it's happening also in ischemic cardiomyopathy patients, not just patients that they have non-ischemic cardiomyopathy. And these are the people we discharge after an MI. And the patients are not in heart failure even after an anterior MI, as you know. And they remodel the non-infracted region of the heart over the years. And then they come back without a new MI, right? So they left from the hospital after the index MI, and they may be even interior. And the EF is probably 40, 50%, 45, 50, 50. And then these are the people that they can remodel this non-infracted area. And this is what we are finding here, right? Now, we will get to the gender differences in a moment when we go down in another study we did. And here you can see typical echo parameters pre-LVAD in these patients before the LVAD went in, right? The dilated hearts, low EF, severe RV dysfunction actually in 20% of them. And you can see here the typical hemodynamics of LVAD patients before the LVAD went in, right? Low index, high filling pressures, and this is sick population, right? You can see how many of them were supported with temporary MCS going into an LVAD. We're talking about really sick people, reflecting the patients you guys deal with on a daily basis, right? And this is, again, from all over the world. Now, we thought that if we're going to show the results of the ones that we win with blue, we need a control group. So we did the same thing the Herfield people did. So we went to the ICGLT registry now, and we got, because this is an international group of patients, we went to ICGLT, and we got an equivalent control group, and we propensity matched the two groups, because this is not randomized, right? We said we're going to go to the registry and get all of the post-transplant outcomes and compare them, right, with an equivalent propensity matched group between the two registries, right? And you can see the results here, consistent with what I showed you before. Up to 10 years, now we have 15 years of follow-up. You can see the results are pretty good, right? They're similar, essentially saying that we can sequentially combine these two options to prolong the life of our patients. And I'll get to this point in a moment. As we discussed yesterday, and you guys asked me this question about the partial responders. With the blue line here, you can see the ones that, with the green, are the ones that they met the criteria for recovery, and we will talk about this criteria in a moment. And the pumps were removed because the hearts looked better. But in the blue, that was the surprising part. We had 73 when we did this analysis. Now we have more than 100. That the pump was removed not because they met this criteria, but because they had a serious complication, like an infection, thrombosis or something, and we've been there. And when they look at the heart, it didn't meet the criteria, but it was a little bit better. The so-called, as we said before, partial responders, right? I showed you before about 30% of the patients are like that. That they will get an improvement of the EF, maybe they went from 10% to 30, from 15% to 35. They were partial responders, but they didn't meet the criteria to go all the way to 45, 50% EF, right? And the surprise was that this line, it didn't go like that, as we expected. They became what we call stable HFrEF outpatients, as you can see here, right? And the Duke group, which is part of our registry, is having a project now, nailing down this group to understand the predictors of partial responders that they can predict stability. And more work, and they just presented this in ICGLT, and we will have more things coming with the publications from the registry. Of course, when we started this presentation, I talked to you about the heterogeneity of the disease. So we looked into the heterogeneity of the causes and how this affects the recovery. And you can see here that we presented this recently, and the paper is under review, that across the heart failure etiologies, once you meet the criteria, the results were similar, even after chemotherapy, which we know that it tended there to be worse than the others, but it didn't reach significance. And these are the results we have right now per etiology. And this is the echo EF, again, per etiology, and you can see how it went up and the stability over the years per etiology again, after you removed the LVAD and you wean the patients. Now, I was asked last night at dinner, hey, this is a practical question, right? How are we going to take out this pump? Are we just decommission it in the cath lab and just bury the drive line and we're done within an hour? Or are we going to go do surgery and remove the pump now, right? And I cannot break and provide all of the information given that this is supposed to be presented next month in Boston in ICGLT, but I can share with you that the summary of these findings, right? That they're about the same, actually, and this is good news because the minimally invasive approach had about the same survival long-term, but a little bit more, as you will expect, infection, abdominal infection, if you leave everything in. And now the studies that they're doing The sites that they are doing decommissioning are doing PETs in order to know if there is something brewing there, and then they go for explantation instead of decommissioning. And I think this is eye-opening, and it's going to give us even better results down the road. Now, as I said before, this is an opportunity for centers like yours for participating in a registry and get the data and submit your own ideas, because you can submit the patients that you will have, and then you will have access to all of the hundreds of patients in the registry. That's what happened. And we presented last HSLT 10 projects and ESC, and next month we will be 9 projects to be presented from institutions all over the country and the world, right? And so that's an opportunity for you guys as well. And this is the steering committee that runs the registry with me and Snehal, and you can see there are surgeons and cardiologists from all over the country and the world, and you can communicate with any of them or me, and we can just get you signed up. It's a simple clinical research project. And we have formed 4 working groups. You asked me yesterday about how to win and the standardization of the protocols, right? And you can see here that the first working group, led by Emil Najar from Karolinska in Sweden and Kuei Ton from MGH, is how to win. And we are essentially gathering all of the protocols and providing a standardization across, right? To develop best practices from all of the institutions, how to long-term manage these patients. Risha Garwal from Duke and Milana Yusuf-Polskaya from Columbia are leading this working group. Surgical approach from not just the explant, the commissioning, and we just talked about that, but also from implant and the things that you need to do at the implant in order to get prepared for later, right? So there has a surgical working group led by Alex Bernard from Hamburg and Stefan Schuller from Newcastle in England. And then the most popular working group is the genetics one, led by Carlos Diaz from Barcelona, Omar Weaver Pinzoma MNT, who is now in Miami, and Ray Heschberger from Ohio State. Now, this working group on genetics is very popular because we get this question all the time. How about genetic cardiomyopathies? If it's in the genes, are they going to recover? And how are you going to do it if they recover? And all these things, right? So we know that genetic cardiomyopathy patients do recover. And we know this from GDMT, right? We know this from CRT. But here is a paper that they recovered after an LVAD, and it was published in JAMA Cardiology. And we know that the tidine truncation example, the tidine mutation, had equal recovery in long-term outcomes as the non-genetic cardiomyopathy patients. Of course, there are other mutations that this may not be the case. We have malignant mutations, more than that, right? Or we have benign. As we know, this is an evolving field. It's a very big, growing field. And so that's why we formed this working group, so we can get better understanding. And that's one of the exciting things happening as part of this registry. Now, as we discussed before, this is not all about survival. Exercise capacity and quality of life is important. This is an important study out of England. And you can see here with blue the healthy volunteers, and this is their exercise capacity, right? And you can see with orange the patients that they explanted and they removed the LVADs, how they did with stratified by age group, right? They were about the same as the healthy volunteers. So these people, they have good exercise capacity. And then you can compare them with the LVAD patients that they did worse, right? And of course, the ones that they were waiting for heart transplant without an LVAD, they did even worse, right, as you expect. And so this is to give you some idea of the exercise capacity these patients have after you win the LVAD. And here is the durability over years, right? You can see the durability here over the years. Now, how to put all this together and implement shared decision making. What day of the week is your selection meeting? We do it every Tuesday. What day is your selection meeting? Wednesday. So on Wednesday, you're going to gather in a big room like we all, and we will have the surgeons there, the cardiologists, the coordinators, the clinicians, the teams. Everybody will be there, right? And we will talk about our candidates and our problems we have with the ones we did already, and the team comes together. So how to put all these things together and make shared decision-making and practical recommendations, right? So we asked this question in the working group that the NIH put together just a year and a half ago. And Lynn, Alana, Frank, and Renee led that, and I had the honor to be one of the people there in the room. And so the recommendations and the summary from this working group is published on the NIH website, and the paper just came out in JAMA Cardiology. Now, One of the opportunities for improvement that was identified was to improve the D-durable MCS as a complement or alternative to heart transplant. Essentially, what was one of the things we discussed is that if we can identify heart transplant candidates with a recovery possibility enabled by durable MCFs, we can use these to delay or obviate the heart transplant need, right? That was essentially what the working group was saying there, is that if a patient has high chance to recover, maybe you should not go straight to transplant, as we discussed yesterday, right? Maybe we can try first VAD and GDMT, and if they don't recover, then we can go for transplant, right? Everybody wins. Now, is this attractive to patients? We think it's attractive, especially to young and middle-aged patients. So why it's attractive to postpone transplant to young and middle-aged patients? Well, this is why. This is, as we discussed yesterday, this is why. And the reason this is important is because if you are 18 to 39 years old, you will get to transplant if you survive the first year. This is conditional, so it's 13 years. If you put also the non-conditional, it's lower. But let's say that they are young, they will do well, they will survive the first year, they will get another 13 years in total. And if you are 40 to 59, you're going to get 11. Well, if you're 25 years old or 35 years old, your dream is not to die when you become 40. And that's why, for younger and middle-aged people, it's okay and it's great if you can postpone transplant for later. Another fallacy in the field is that this is per graft. No, this is not per graft. This is even with retransplantation. Because, as I'll show you later, the problems we get in these people are not going to be only related to the heart, right? And you can see here that with retransplantation, these are the outcomes. Now, why? These are some of the issues we get post-transplant. Renal dysfunction, diabetes, CAV, and you can see here the outcomes. I'm going to focus on the diabetes. This is my partner, Josh Stalik, who directed the HLT registry for years, and they looked at 2,600 patients that they had diabetes before transplant, which, as we saw, it's happening, as you saw here, 1/3 of the time. In these 2,600 patients, their 5-year mortality was 50%, which is how we grew up saying that if you get a heart failure diagnosis, your 5-year mortality is going to be 50%. Essentially, we gave them the same disease back in 1/3 of the patients. So that's why this is better to avoid it and push it for later if you can. Not to mention the malignancies, right? So for these reasons, if you can postpone transplant for later, it's good. Of course, the LVADs also have complications. People will say, we're not talking about something. We talked about it yesterday, right? And this is the Intermax registry in younger people. Last year, that was the focus, right? And this is the results. And you can see here the complications, right? And the complications, as you can see here, right, in the Intermax, they're getting better, but there are still real complications, right? You can see here the stroke, the freedom from stroke, freedom from bleeding. So there are complications. Both options, they have pros and cons, right? And so what was the conclusion in this was that if we can get the patients with a pump, right? Again, this net prolongation of life point, right? And we can give them a few years on the pump and then transplant them, we may get them farther away than giving them directly a heart transplant. Now, when this was presented recently in THT, a couple of people in the audience, I was very glad to see standing and saying, well, this is taking the VAD for a few years and then adding the heart transplant in order to prolong the life. Well, in some of these patients, when you put the VAD, you're not going to go to transplant, you're going to go to recovery. So you will add additional more time in them, and then transplant them later if and when the heart failure comes back. So you can add even more in the population of the candidates that they can recover. And so that's even more attractive. Now, essentially, what we're talking about is that we should first try in patients that they have high chance to recover this GDMT and VAD path, right? And this will have implications that they will be kind of win-win for everybody. What do we mean by win-win for everybody? Well, if we avoid the complications of immunosuppression that we just discussed, right, and many years later heart failure recurs, then we can transplant them at that point. As we saw, some of these people may get 15 years or even more, right? Now, the donors that we're not going to give in this patient that you have in front of you is not going to be wasted. Somebody else will use it, right? We have all these people waiting there. We don't have donors for everybody. So we're going to reduce the waitlist mortality, and you will benefit other people listed, your own patients in your list, right? So everybody wins. And this way, you will maximize the impact of both transplant and LVAD for our societies, right, and our patients. Now, UNOS is the organization who arranges the allocation of organs, right? And so we discussed with them to expand the safety net that they're doing for the kidney. Essentially, this is when they tell you, don't take the kidney and just go for the heart. Don't do combined heart-kidney. In these patients that they have heart failure, as you know, the kidneys also begin complaining, right? You've seen this every day. And many transplant programs, instead of just transplanting the heart, they're transplanting heart-kidney at the same time because the kidneys are borderline. So UNOS saw that. And in order to incentivize us not to take the kidney in borderline patients and leave it for somebody else, they say just go for the heart transplant. And if during the first year, because the immunosuppression is also nephrotoxic, right, as we saw, right, if you get kidney dysfunction, we will give you the kidney donor with priority. This way incentivizing us to not take it up front. So we want them to do something similar for the heart recovery pathway and incentivize teams and clinicians, right, to try first the recovery path in patients that they have high chance to recover. And if they don't recover, then you can reward it with waitlist priority later. So that's what we've been negotiating now and asking UNOS to do, using as conceptual precedents what they already did for the kidney. And this is something we just submitted, as you will see. Now, as it says there, this is something we are asking them to do in people that they have high chance for recovery. So you may be wondering, who are these people? Who are these heart failure advanced patients that they have high chance to recover? Can we identify them in your Wednesday meeting and make shared decision making? So patient selection. It's something we got into, as you can see, because it has practical implications. We started looking into the tissue, and we saw that the T-tubules in most of the patients have these clusters with the RYR receptors. In some of their patients, they have these sheets. They're not T-tubules anymore, and they have non-junctional clusters. And what we found there was that the ones that they have these are not going to recover. We're not going to be able to do this for your Wednesday meeting. Who's going to do that for all of your patients? So we needed to look deep initially, right? And then the editorial says this is a microstructural point of no return and all these things, right? But this is not practical. We're doing it for reasons that you can imagine scientific to understand recovery and all this. We can develop more therapies. But the low fibrosis was something else that we got interested in. And this is the heart, this is the epicardial fat, this is the endocardium. We stain, we can measure interstitial perivascular total fibrosis. You can see here with blue the collagen, right? We can measure that. And what we found in this study that is under review right now, and we were surprised, right, was that there's a group of heart failure patients that they have low fibrosis despite being advanced end stage. And we were surprised when we saw that, but there's a German group that reported the same thing. So there is a group of advanced end-stage patients that they're not going to have increased fibrosis like we expect. And this is comparable to the donor hearts. And that's the first finding we found. And then the second finding we found was that it rejected our hypothesis. What was our hypothesis? Well, our hypothesis was that if you have a lot of fibrosis, you're not going to recover. Common sense, right? If you have a fibrotic heart that is burned out, you're not going to recover. And what we found was that, no, it was not predicting recovery. And I'm talking about interstitial fibrosis, not the replacement scar of an MI, right? So the interstitial fibrosis, we now know from aortic stenosis patients and others, the interstitial fibrosis is a dynamic thing, right? It goes up and down. And so that's why the ones that they recovered, you can see them here, they reduced their fibrosis, the interstitial fibrosis. And the ones that they didn't recover, they didn't reduce their fibrosis. So our effort to do MRIs before and see who has a lot of fibrosis and select the patients this way was rejected by our own data. So you cannot really use interstitial fibrosis to identify the patients that they're going to recover. So we kept looking, right? And then we did rotational mechanics. This is Michael Bonyas, who is one of our trainees that worked, and now he's an independent faculty at Onassis in Greece. And when he was in Hopkins, he learned from Ted Abraham to do rotational mechanics and torsion, right? So all of these people have low EF. But there is a subgroup of them that the torsion, the rotational mechanics is better. And we hypothesize that these are the ones that they will recover. And indeed, what we showed in this paper is that the ones that they have better torsion, they can recover. But we cannot do torsion. I mean, this is a super duper expert study that Michael did with Ted Abraham. So we cannot do this every day for our Wednesday or Tuesday meeting, right? So we needed something more practical than that. So then we went to the blood and said, maybe we can measure something in the blood. And indeed, we identified from the tissue and then in the serum that these two cytokines, TNF-alpha and interferon gamma, can predict the recovery, right? And we published that. Do you measure for your Wednesday meeting TNF-alpha and interferon gamma, guys? No, you don't measure that. So that's also not practical. It's not going to help you this Wednesday to select the people that you will recover. It's good for science and for us to understand the mechanisms, but it's not practical. So we went to do practical things, and we said, can we become more practical and precise and select these people, right? So that's why we published this ICAR score. And this is Omar again, when we got the Intermax data, right? And we identified these predictors, which is similar to the things I told you before, like the younger the patients, non-ischemics, not as dilated. We'll come to that. And we came up with these tiers for high, intermediate, and low probability. But you see here, if the strategy was BTR, bridge to recovery or not, and then how we validate that in our Utah cohort. So this is giving you tiers and patients on simple things. And so we said, yeah, it was good enough, and we were using it actually every Tuesday in our selection meeting, and I heard that you guys also calculate something similar. But we wanted to make it even more precise and personalize it, and make it apply to each patient's characteristics, and give the patient a number, 10, 20, 30%. So that's why we created this calculator. These are the 4 sites that developed it, and we validated in the following 4. And then we came up with these 4. We had a derivation cohort and a validation cohort, right? Multi-center, almost 900 people. So these are the 4 characteristics that they go into the calculator. And I'll show you examples. So this is a patient, non-ischemic cardiomyopathy, biologic female, 72 months out after the diagnosis, LVDD of 6.6, 25% recovery rate. Personalized prediction for this patient for your Wednesday meeting. It's another patient, 44 months out, 6.5 centimeters dilation, 30% probability. This is another lady, non-ischemic cardiomyopathy, 11 months out, less dilated, 40% recovery. This is another patient, 6 months out, not dilated yet, 50% recovery rate. So you can personalize that, and the patients and the families and the clinical teams can employ what we call shared decision making. And we can make this available to you. It's under review now, but as we discussed yesterday, you can start using it. It's a simple thing. Now, how about the right ventricle? Are we just going to recover the left ventricle here? Because as I showed you here, this was predicting what? LV recovery, right? LV recovery. How about the right? Because if the right doesn't do well, as you know, we have problems. So that's why we already published RV failure scores. And this is the calculator that we just published in JAMA Cardiology. This is already out, and you can just go find it and do the calculation. It's also free on our website. If you Google our team's website, you will find it, or you can just use this QR code. And you can calculate for each of your patients every Wednesday in this multi-center study we've done, and you can see the centers, the chance they have for the RV to do well or not do well after an LVAD, because you need both to do well. Now what we're doing is doing clinical characteristics and biological data together in machine learning in order to inform even better this prediction for the right and the left ventricle. So let's go to the underdiagnosis and the underutilization of this path and the magnitude of opportunity. As I said, in Intermax, this path is being utilized 1 to 3% of the time only. But if you go in Intermax, in the same Intermax that you see that, you find that the percentage of patients that they have significant heart improvement is 10 times higher than that. That's the magnitude of the opportunity, right? It's like having an electric car company and saying only 5% of people have electric cars? What's the magnitude and the share opportunity for me and my business? Well, I can get it to 50, 60%. So here it's 10 times more. Underdiagnosis and underutilization, right? This is from UNOS confirming what we found in Intermex. So this is the Mount Sinai group. And what this group did from New York, they went to UNOS, which is another data set, and they found there that the majority of the sites had zero recovery ever. And then they had 35% of the sites that they were doing it. And what they wonder is that, well, these 35% of the sites in the country are not treating a different species of patients, right? And so that's the conclusion they arrive. There is a huge discrepancy here, right? Now, going back to the zebra question, yeah, this is not a zebra, but it's also not for everybody, right? So as we saw, it's about going to be 15% and another 30% partial responders, right? And this is not something that is happening only in super duper sites. This is hundreds of surgeons and cardiologists from all over the world, right? And hundreds of patients. So this is something that you and everybody can do, right? And as a kind reminder, we talked about it yesterday for our trainees and early career people. When SGL2 and Entresto were approved, it was easy to get them in. But as a kind reminder, dogmas, which is something that, as you know, troubles medicine, these are two dogmas, the antibody-mediated rejection and the beta blocker responder, that they were also considered rare zebras for decades. That they were, I mean, the beta blockers were working only in Sweden and Utah and Colorado for 30 years. As you know, they don't work only in these places. And AMR was something happening, the antibody-mediated rejection, only in Utah. As you know, it's not happening only in Utah, it's happening everywhere. Now it's one of the most hot transplant topics. So we should always be open in medicine for change. So what do the guidelines say? The guidelines, even before the registry results that I showed you are out, and I had the honor to be in this guideline committee, they now identify this as a big opportunity, and they added a new section, as you see there, about how to select these patients, how to optimize these patients, right? And how to evaluate them for recovery, and this is published. And what are the action items to take advantage of the opportunity and overcome the barriers, right? So I'm going to go through them with you. Many centers do not have recovery programs. It's not even an option, as we said. This dilutes the incidence. In Intermex, this is actionable. It's straightforward, actually. Why straightforward? Because in order to have a recovery program, you just need to do two things that you're supposed to do anyway. You're supposed to do GDMT 4-pillar in all of the HFrEF patients, including LVAD patients. And that's the major thing you need to do in order to have a recovery program. And then you need to do an echo every 3 months for the first 6 to 12 months. And you don't even need to do a turn-down echo, just a screening echo to see if the heart is getting better. This is not, I mean, it needs some coordination, but it's not something, anybody can do that. Any program can do that, right? So, and then if the patients show that the EF is more than 45%, then you can do the LVAD weaning evaluation, which is also not that complicated. You guys, as we discussed yesterday, you've done it already. So you can just turn down the pump in the cath lab or in the ICU, and then you can do an echo, right heart cath, and even a cardiopulmonary exercise test, which is optional, right? And then if you do, these are the criteria that they were used in restage by echo and by right heart cath, right? When you turn down the pump. I mean, this is the bar, normalization of the dimensions, and the EF more than 45%, and then normal wedge and normal index. And if you see that, right, then you can just take the pump out. What we do now is, in addition to this, in our program, is that keep the patients in the ICU for 1 day with the swanning, just to see a little bit more prolonged than 1 hour or half an hour in the cath lab. More details we just published in this invited paper where somebody can just go see a protocol in detail how to do that. And that's one of the barriers that is actionable. The other barrier was the uncertainty in the field about the durability of this recovery. We talked about it yesterday. Not anymore. There's no uncertainty anymore. We have now multi-center studies. Another barrier was that we didn't have tools to identify who are these guys, who are these people, who are these patients that they're going to recover. Not anymore. We have several studies now that they help you to predict who are these people. We even have a calculator. You can personalize the prediction, right? And you need to incentivize people to try first this path and not go straight to transplant. And that's why we've been talking to UNOS, as you can see here, to incentivize patients to try this and give them priority for transplant later. Because even if you have 50, 60% chance to recover, this means that you have 40% chance not to recover. So you need to incentivize these people, if they don't recover, to get the transplant later, so they can try that. Otherwise, they will go straight to transplant, and then you're going to miss the opportunity. Now, have you ever had a patient that came to you, and then you wanted to send this patient back to the referring cardiologist, and the patient didn't want to go back? That's a very awkward position to be. It happened to all of us, right? So this is the story I'm sharing with you now. We got a patient from New York. They didn't have a recovery program. They recovered the heart. They sent them to our surgeons to be the first case. They came to see how we do the explantation. They can start. And then the patient comes to us. And then when the patient was going to go back in New York, the neighbor of the patient got this magazine, and they text the patient and the wife, and they go, you should not go back to the hospital. You should go back to Montefiore because they already have a recovery program, and they are already doing that, and they have this campaign now. And so this is happening, and when you are in places that there's a lot of competition, you will get problems like that. So this is a real story. Now, future direction, I'm going to go quickly through that. We talk about this sorry guys. We talk about this missed opportunity here. How about these partial responders? How about these people, right? Well, what happens to these people and the non-responders, right? Is there any missed opportunity there? Can we do better with GDMT and hemodynamics? This is data from Chicago and Innova saying that you can see here that there's a lot of room to improve in LVAD patients, the hemodynamics, right? Only 50% of the patients were in the range we want them to be, and 30% here. So there is room to improve the hemodynamics. And another way to do that is to combine the cardiomems with an LVAD, and this is the Intellect 2 that I had the honor to lead. And what we did there, and I'm summarizing the results in 101 patients, we combined the cardiomems with LVADs. It's feasible. And the ones that they had diastolic less than 20, they had lower hospitalizations and improved 6-minute walk test. And this is the magnitude of the effect on the lower hospitalizations and the 6-minute walk test increase with blue here. Now, we have the TEAM-HF study, which is ongoing. And this is prospectively examining PA pressures in cardiomems patients. And if the pressures do not go down within a 3-month GDMT, then we randomize the patients either 12 plus optimal medical therapy versus only optimal medical therapy. Now, is there room to improve GDMT in LVAD patients? This is embarrassing for all of us. In Intermax, and this is JAMA cardiology, only 16% of the patients were on the standard triple when we had triple. I mean, yeah, there are people that they may not tolerate all of the GDMT, but 15% of the patients only, this is embarrassing. So we have room to improve GDMT in LVAD patients, as you can see here from real-world data, right? So if we do that, then we may be able to recover more people. Now, target populations, the GDMT-naive shock patients that they can have now an accelerated path to transplant with impella or balloon pumps and all this is a population that we need to focus on. Why? Well, if you look at the UNOS data we analyze and we publish, after the allocation changes in 2018, the percentage of patients that we have recovering went down 8 times. And this is the editorial explaining why, because now we can accelerate transplant these people with the allocation change. We were not waiting for recovery. And these need to change, because within a few months, it went 8 times down. The patients didn't change within a day or 2 or a month. They were the same. Now, this is the other patient population with suboptimal GDMT due to symptoms and hemodynamics, and this is the chronic heart failure population that I just discussed with you that they have the calculator, right? So these are the people that we can target in order to do that. And then the goals and the impact will be to rescue hearts, postpone and avoid transplant, which is attractive in young patients, as we discussed, improve the allocation of donors, and by the negotiations we're doing now with OPTN, these are the people that they co-signed from all over the country. This petition we did in order to develop 2 tiers, in order to give prioritization based on specific criteria to patients. And then the other benefit of this is that by taking the tissue, as I showed you a couple of things, we can advance our understanding of the recovery and benefit the whole field with identifying new therapies for heart failure. So with this, I'd like to end it here and open it to any questions that you guys may have. And thank you so much for your attention.
Yes, my name is Sheriff Dodu, final year cardiology fellow. So have you looked at the interplay of social determinants of health as it plays on recovery of patients? Because I'm thinking that even though there may be some patients that would have potential for recovery, they may be young, their LV and diastolic volumes may not be that high, or the dimension may not be that high, that predicts recovery even after LVAD. But there may be some social determinants of health that may prevent them from showing that potential of recovery. Have you looked at the interplay of that?
Excellent point. We're doing it now. And we should have, this is an excellent point, and this is what we're doing now. We have not published this yet, but we're looking into it as we speak, because there are many ways that this can affect what we're seeing. And our prediction is that it will really be, and I can share with you some preliminary results, that it really counts. We're just trying to understand a little bit better what we are learning from that. Thank you for this question.
Thank you, Dr. Stavros, for that. My name is Tochukwu Lillian Tanko, one of the first-year cardiology fellows. I think my question is in terms of the duration. So how long is too long a wait to see about the myocardial recovery with LVAD in terms of like explantation of, moving them forward for heart transplantation?
Excellent. This is a very practical question. Essentially, the question is, just for the people online, if we're going to freeze the candidacy of somebody on the waiting list to see if this patient is recovering, how long are we going to freeze it, right? Or if it's in a center like your center, that you don't have a transplant program and you're going to send them somewhere else, how long are you going to keep them here before you send them to the program to get transplant? That's the question. It's a very practical question. And if you remember, I showed, but I didn't emphasize the time frame of recovery, right? So when you get an LVAD, within 3 to 6 months, now we have studies from all over, you will see the heart getting better. It may not complete it during these 6 months. It may not plateau the improvement by 6 months. But if you see zero, if you see nothing, and you have already treated the patient for 6 months with good GDMT, we know this from our regular HFrEF patients. If you see zero improvement in these patients, then you may say, hey, this is very unlikely that this will lead to recovery. Usually, we see the plateauing between 6 and 12 months, right? But by 3 to 6 months, you should be able to know if this patient is recovering or not, and then divert the patient to the transplant path.
Oh, yeah. Good morning. This is Vikram Rajay, one of the heart failure and IC docs here. First of all, congratulations to you and your team in advancing this field. I know you've done many years of this work. I've heard your talks at other meetings and heard your talk of ECU 10 years ago, but thank you so much. Thank you so much for leading this field. My question was more of a program question. Do you feel that this hasn't taken off as much as we all would have liked because of biases in our field, or do you feel that it's more we know what to do, but we're just not doing it because we don't have the plan and the logistics of how to do it? And then second question is, have you studied LVAD speed? To me, it thinks, at least naturally, the higher the speed, the more recovery.
Yeah.
Is that a good way to think or not really?
Yes. So I'm going to start with the second, which is quick here, and then I'll go to the first, which is the real thing, as we discussed yesterday. Yeah. Right? So yes, the LVAD speed, essentially the optimization of the offloading, is very important. And what we do in our program, and I'm sure you have a protocol as well in order to do the speed optimization, is we look at the heart by echo and we make sure that the speed is the one that is going to keep the IVS in the middle, the MR is going to be minimized, and will allow a little bit of the aortic valve to open, which this may mean that you may go down instead of going up. But the first two, to keep the IVS in the middle and to minimize the MR, right, if there is a residual MR, are the first two criteria. The allowing the aortic valve to open is a third criterion in our program, prioritization. And so by doing that, we optimize the speed. So it may not be always higher, right, but most of the time it may mean going up on the speed. We do this at the end of the hospitalization when they get the LVAD, and then we do it regularly, maybe every year or whenever the patient doesn't look good. We call these speed optimization echoes. Now, the other question is change. right? And as you know, this is an issue that we see not only in medicine, everywhere. If you're suggesting something new, you need to, we discuss about the beta blockers, right? It took 25, 30 years. So it just needs things like this, right? We get together, we talk, we show the evidence, and then things may change. There are many reasons, it's not just biases, right? There are financial reasons, financial incentives sometimes. So we need to get also the regulatory bodies to give credit and financial incentives also sometimes for things to happen, right? And then give credit to the programs with performance status criteria, right? This is another thing that can happen. And education, as you said, and having the protocols, having the plan. Some people, if they have never done it, right? That's why we are doing all this, right? And I'm glad that you guys are inviting us and other colleagues from our network. And we also needed to do some work, as you said. We started talking about that and others. I got introduced in this field 25 years ago from one of my mentors, right? I'm just gonna be now the devil's advocate. If I say something new, people should not just jump on the wagon and do something new immediately, then it will be crazy. You need to validate that, you need to show that, it takes time, right?
Good morning. This is Hussein Majid, one of the third-year residents in internal medicine. Thank you so much for speaking with us today for a very thorough presentation. You mentioned some blood markers in terms of the heterogeneity of myocardial recovery and heart failure. I was curious to know if there was any genetic markers that are being explored where you can use for selection of myocardial recovery pre-implantation of LVAD?
You're asking good questions. Last night, today, yes. I have a great group here. So, yes, I showed you my trainees and fellows and colleagues who are now independent all over. And one of them, Omar Weaver-Pinzon, who I said is NIH funded, that's his NIH project, looking into genetics and epigenetics of recovery and seeing whether we can find something there that can predispose these people to recover, right? And that's exactly the project. And we will show something at ISHLT this April, and soon we will have even more evidence to share with you. But we're looking into it. It would have been a miss to come from Utah, where we have all this genetic background there and research, and not do genetics. Yes.
Hey, Dr. Drakos, nice to see you again. Thank you for your excellent talk. You mentioned briefly in your recovery probability risk calculator whether or not they're on GDMT, it should be accounted in that. Just about how much should we account into the calculator?
Yeah. So that's a great question. The recovery calculator, as you saw, did not include the factor which sometimes gets when we evaluate the patient, that this patient is GDMT naive. Essentially, I showed you there the gender, the etiology, the dilation of the heart, right? And the how many months, years they had heart failure symptoms. These are the four things. So whether you are or not GDMT naive and you try GDMT was not included in the calculator because the way we designed the study was not captured. And this is, I think, one more thing that when you have a GDMT naive patient, you should add. And the question is, how much more to add for that? Well, I think you should count a lot. I cannot give you a percentage of how much more you should expect recovery if somebody is GDMT naive, but I can say something that I think it will be helpful. The guidelines are telling us to not even put an ICD in people before we try GDMT. And we're going to do a transplant? They're telling you not even an ICD, to first do GDMT and then put an ICD, right? And we're going to do a transplant? So that's my point. If somebody's GDMT naive, you should do everything you can to try them on GDMT. And the GDMT, as we know, is getting better and better, right?
This is from Dr. Mock. Thank you for the wonderful and insightful presentation. What type of upgrades or new features would you like to see in current LVAD technology and why?
Oh, that's an easy one. And the reason it's easy, I think, is because what we would like to see is the driveline go away. There are many things we would like to see, smart pumps, sensors, but the number one thing that will make the field take off, it will be the driveline coming out of the belly of the patients going away. Why I'm optimistic that this will happen? I'm optimistic because we are a small field, and right now, there is a huge field that you are all familiar called electric car batteries field. That the market is not the niche advanced heart failure market, that how much investment you will get to build VADs and do transplant research and all of this. So there are engineers right now all over the world racing with a huge stakes there, who is going to win this race to get the batteries to become smaller and more durable. And this technology will be transferred, because that's what you need, right? You would need to get the VADs to look like a pacemaker, fully implantable and forgettable. And when this happens, and I'm optimistic it's going to happen because it's just not us, but there are a lot of other people stronger than us and with more investment looking into it. That's the number one top change that I would like to see. And I think when we see that, then it's going to be the next step, which I think will be transplant for people that they are more than 50 or 55 years old, that you can get them with one through, and all of the others, they will just go in GDMT and other platforms like VADs, that they can keep them until that age. And then when you get them at that age, then you will transplant them, and then you will get them through with one transplant if they need transplant at that point in time. And I think this is where things are going.
All right, well, thanks everyone for attending. Thanks again, Dr. Drakos, for that wonderful enlightening topic. We'll look forward to seeing you guys next time for the next ground rounds. Thanks again. Bye-bye.
Thank you.